So I'm sure we'll see more of nanobodies and hear more on nanobodies in the next CLINAM. Something we've also never heard of. Do we do Groitzen at the end? Or? Because I was going to introduce optical surgery. Which one is the next talk? Can you please put up? Yeah? Okay. Good. So then we'll wait with the surgery part. This talk will then be... No, it is. Good. Groitzen? Please. So something we've never heard of, at least I have never seen at CLINAM, is the use of targeted probes for surgery. So you can actually make very small particles. Some of them are in the low nano size, I would say, to target tumors, to actually enhance the removal, surgical removal of cancerous tissues from the body. And Groitzen van Dam is a pioneer in this. Very happy that he made it this year. We already invited him last year, but then something came in between. I'll not take any more of your time, Groitzen.
Yeah, thank you very much. I think we're going up and down in sizes. Liposomes, nanobodies, and now I'm here back with the antibodies. But it comes true to the concept, what's already discussed, and I almost feel historical. When we started it, the idea was to use drugs as imaging agents, and it's a very exciting crossroads we're actually ending up to with comparing antibodies with nanobodies with liposomes. And what I want to show you today is our perspective at the time when we started this, and this was 2007 for image-guided surgery. What is better? Antibodies, nanobodies, liposomes? We don't know. I mean, we work with a startup company, Oncology, in Dallas, which makes pH-sensitive liposomes. So we will see what happens there. We want to initiate and already started to produce GMP our own nanobodies, VHH, to see what is best for me as a surgeon. And Theranostics, in this respect, is not related to a drug, but you should see me, the surgeon, as the theranostic part. Although it's not completely true, because I also want to point out the potential of using a nanobody or a liposome delivering, like, for instance, a photosensitizer as a theranostic agent. So not using light so much as a red flag technique, but also using light as a photosensitizer to treat at the same time. So moving forward, I want to point out the way we do procedures now. Prior to surgery, everybody knows we do all kinds of non-invasive or invasive imaging, like ultrasound, MRI, PET-CT, and every part has its specific, let's say, sensitivity and specificity for a particular disease. And although very dynamic, I find it very frustrating that actually the left part of the slide is not very dynamically being used in the OR. Prior to surgery, I look at segmented MRI data, I look at PET-CTs, and basically prior to the day to surgery, I basically stash it in my head and reproduce it during surgery. The most astonishing part, actually, one of my Ph.D. students was measuring and looking at what is presented on these big LED screens like we have here in the OR. You know, every OR has these fancy LED screens, and most of the times it presents the menu of the restaurant of the university at that particular day, and not so much the images we make prior to surgery. And there is something quite a lot to gain. And there's a lot of actually effort made in this particular field to fuse these images into an OR setting. That's not the topic of today. The frustration comes from that particular part, because at some point I started to realize in 2004, together with Vasilis and Christos at that time, can't we develop a more real-time technique into the OR without the expenses? You know, there are already the so-called hybrid ORs with PET-CTs and MRIs in the OR, but they're very impractical. They're very expensive, up to millions of euros, I would almost say dollars. And so we were basically looking for a technology which would be easily adaptable in the OR, and we thought, why not use optical? And more recently, but that's not all. Most of the technology has been developed in Harvard Medical School or in the Technical University of Munich, about which we're working with. And more recently, we expect that optoacoustics will make its entrance into the OR. I will focus on optical. So I already mentioned as a surgeon, for me it's difficult, although it seems to very obvious sometimes to detect where the tumor is, the boundaries of the tumor. So when I excise the tumor, there's microscopic residual disease, most of the times. Varies per tumor type. Breast cancer, it's up to, let's say, 20%. Pancreatic cancer, an astonishing 70 to 85% positive margins. I'm an upper GI surgeon, so in my particular field of clinical activity, it's even up to 30%. So that was one of the things we wanted to track and basically track down the tumor and treat, so cut out the tumor with more safety margins, be more efficacious. That was one of the mainstays. We developed for that particular reason molecular fluorescence guided surgery, so not a specific traces, but more specific traces, and they're most of the time antibody based. The other part was, if that's the case, if we have this targeting moiety, why not hook up this photosensitizer, so we not only see it, we cut it out, and in case of microscopic residual disease, the knife is not the answer, but instead use a more sophisticated technique like photoimmunotherapy. So this is the way we do surgery now, and I will show you the number of clinical studies we have embarked on. Basically what we do, we inject the antibody. A disadvantage compared to a nanobody is its long half-life. You need to wait, and I will show the data in a moment, 3 days before you have the optimal target to background ratio. In this case, we actually used a nanobody bevacizumab in breast cancer. Was the first clinical study we have very recently published on in breast cancer. Evan Rosenthal from Stanford has published on cetuximab in head and neck cancer, similar approach. What we do, we image, of course, in vivo, and then we have developed a so-called standardized operating procedure for really tracking down the tracer, the fluorescent tracer. What is the tumor microdistribution? Does it actually assist the pathologist in cutting certain parts within the specimen? What is the distribution of the tracer in relationship to other tissue characteristics like the microenvironment, neovasculature, etc., etc. And this is the process we have now, I would say, optimized, and we're using actually in multi-center studies now for validation of how a fluorescent tracer at the end of the day ends up in the tumor. So this is what we call not only the image-guided surgery part, it's the image-guided pathology part. So instead of minutes of and hours of processing for like a frozen sectioning, or in this case, sorry, for the frozen sectioning, or for final histopathology, we really want to cut down this in minutes to hours. So you really get a much better idea outside of the OR and basically bringing back the pathologist inside in the OR at the same time, giving a more adequate answer whether or not we have left tumor behind, which gives immediate feedback, and we call it fluorescence-guided pathology to the OR. We use several targets. At that time, more or less the most prevalent one, which was bevacizumab. We were actually piggybacking with our fluorescence-guided surgery on the zirconium studies from Liesbeth de Vries and Guus van Dongen in the Netherlands. At that time, we also embarked on, let's say, EGFR, so and HER2. You already heard about that. So we have developed now a bevacizumab IDA-800, it's a fluorescent tracer, a trastuzumab IDA-800, cetuximab IDA-800, and more recently we have started to work with more smart activatable probes. Coming back to our strategy, so instead of an, let's say, blood pool agent like indocyanine green, we initiated almost 10 years ago, it's 10 years ago actually, with a very small tracer, folate-based tracer in ovarian cancer, and after that we initiated bevacizumab. We're now multiple studies I will show you in a moment. We have started with trastuzumab imaging fluorescent, and together with Evan Rosenthal from Stanford, we're also imaging cetuximab in head and neck cancer. We're not involved yet, although we're looking into a GMP facility whether it's possible to produce this GMP on this particular probes mentioned on the right. So the other part is, if you have an antibody, then you can also use it to hook up a photosensitizer like 700EX. And the group of Kobayashi and the NIH has extensively published on this in Nature Medicine. I forgot to put the reference here. It's Nature Medicine in 2011. There is a spin-off company in San Diego, Esperion, who actually takes this into a phase 2 in head and neck cancer. This is not the topic of today, but it shows its versatility. I skipped this. What we have done, of course, besides the tracer, 10 years ago there was a quite, I would say, almost a malignant discussion. Technology doesn't matter, and if you're a tracer person, you say the tracer is the most important. If you're an imaging company, you say the technology is the most important. I think this has been, let's say, quiet down quite a bit. We use technology which is based and it's developed in Munich, but we have several camera systems available in our center, not only from this particular company, but we have also made quite a few imaging systems in-house because they're just not available. Like a laparoscopy, there are fluorescence systems available from several companies, but they're not sensitive enough to detect the level of traces we are injecting. The same holds true for a complete new field, which I will not discuss today, but it's for flexible endoscopy for gastroenterology applications. We found it very important to have the same methodology from in vivo to ex vivo with the same sensitivity. This was the initial study, already outdated data, I would almost say. In ovarian cancer, a very small trial of 15 patients. We injected folate FITC. Here you can see the compound. It's very swiftly internalized, what we already discussed. That's the nice advantage of it. It's also taken up by the kidney. That was actually later on a little bit the reluctance we had with this compound, because it was not clear how long the accumulation would be within the kidney. Nevertheless, at that time, it was not as well known as we know it now, but it was internalized quite fast, and within 3 hours you could image, here are the gray spots, tumor foci in vivo in patients with ovarian cancer. This is the, and if you in the control room can dim the light a little bit, I'm not sure if the person is still there, yeah, he's there. You can see here on the left how you would see these images with the naked eye. The tweezer points out to several spots. The let's say, experienced surgeon does recognize several spots here in the greater omentum, and this is the transverse colon in a human. And here on the right, you see the difference if you use, and this is just folate FITC, so it's the visible light. It's not a near-infrared probe, but a very superficial spreading disease you can very easily detect with fluorescein isothiocyanide labeled with folate, and quite specific. So the success of this story really made us confident that we should make the next step with antibody-based. And here you can see the number of studies which have actually exploded within our hospital using these kind of tracers. I'm very fortunate that we have a GMP facility, and I think the fact that we used therapeutics at the first place to do this. We even have imaged last week the first patient with endometriosis, an antibody-based, so it's bevacizumab IDA 800. So we have really transferred from oncology to more benign diseases. And we could have done this 4 years ago, but due to the fact that it's fertile, these are fertile women, it's quite a detrimental disease, and based on the fact that we could detect spots on peritoneal carcinomatosis based on colorectal cancer origin, made us decide to initiate this study last year. Quite a lot of work, what's going on, and to show you the images, the strategy in breast cancer, as I already pointed out, 20 to 40% of the patients with breast cancer, primary breast cancer, have a positive margin after breast conserving surgery. The consequences that we do lots of re-operations, which is cosmetically quite detrimental for these patients, or we do actually end up in a mastectomy. So that was the clinical relevance to move into this field. We target VEGF-A, the soluble ligand. So here we are, the total antibody, 150 kD, and of course the VHH already mentioned, 15 kD. It's a different kinetics. We started to do mice work already in 2011, comparing zirconium labeled bevacizumab, which actually now is standard in the clinic, together with trastuzumab in patients with metastasized breast cancer for clinical decision making. And here's the fluorescent labeled antibody. And based on these pharmacokinetic data, and in a nutshell, due to the sake of time, we all image our patients 3 days after injection, which is also the disadvantage, because patients need to come in to the hospital 3 days in advance prior to surgery. Although when you ask them as part of the studies, they are, and of course geographical distances in the Netherlands are quite short, they do not experience this as a real disadvantage. So what do you see after 3 days? Here's a lump, so ex vivo. Here's the fluorescence on one of the positive margins. Here's an overlay. Then we make so-called bread loaf slices, like you cut a bread. Here you can see the tumor quite visible in the rim of the tumor. The pathologist is actually observing this in the lab and cutting particular parts of this part. So it's not only guiding the surgeon whether or not there is a positive margin in this case, but also the pathologist where he or she should take additional slides. Here you can see the FFPE, so the formalin fixed paraffin embedded part. Here's fluorescence, and this is actually microdosing, so it's PET label dosing, but you also see there is some background in several streaks. And if you can see here again the overlay, H&E, fluorescence, and overlap of H&E with the fluorescence intensities. This pointed us towards the fact that we really can go in detail. So we started to segment out parts of these paraffin embedded slides, try to see if there are fluorescence intensities. This is just measured by a flatbed scanner, but also we made ELISA, so we took small core biopsies to measure actually the quantity. And at the end of the day, you can see DCIS, as you can see here. And I quickly show this. This is our standard operating procedure, the lump in towards microscopic analysis. In red, the bevacizumab. And this is the last video which shows the process. And then it should start by itself. Here again, we scan those FFPE slides. And this is actually a process we do in all our clinical studies. So we have the in vivo results, but always come back at the microscopic level. And here you can see that we do cut and deparaffinize the tissue sections for standard immunohistochemistry and combine these with our fluorescence flatbed scan results. This takes a moment and then I will finish. Here you can see, for instance, H&E, VEGF, collagen, and CD31. At the end of the day, this can be presented in several ways. How does the tracer relate to the tissue and the microdistribution of these fluorescent tracers? By having said so, because also due to the sake of time, this is what I wanted to discuss, how we actually have developed fluorescent tracers into the clinic. The clinical practice, of course, is for image-guided surgery, but I think it's important to also to point out that if you want to have a clear decision-making on whether this tracer is useful in the clinic, ex vivo analysis is of the utmost importance. Where are we actually looking at, and is this tracer really hitting the target, as mentioned before? Having said so, I would like to thank you for your attention. More than happy to answer some questions.
Thank you. 1 or 2 short questions? Yeah, please.
Just a technical question. So you show the results on fluorescein, and then you present on near-infrared. So, I was surprised. So fluorescein can be still used. So the mode of, let's say, the green color emission can be used in surgery, or it is just for superficial targets? So
this green is a pseudocolor.
Yeah, sure. But you showed an example of fluorescein.
We initiated with fluorescein, and for superficial spreading tumors like colonoscopy, peritoneal carcinomatosis, head and neck cancer, if you really want to be, because it's still on the surface, it works perfectly.
Okay.
For near-infrared, like lymph node detection or deeper seated, which is much more of importance for instance, for photoacoustic imaging, than a more near-infrared or far near-infrared tracer is more advantageous.
So if you want to go to a robust imaging agent for therapy, it's better near-infrared
That's what we've chosen. Now we do not, to be very honest, we do not use fluorescein anymore. We only work with the near-infrared dyes.
Yeah, okay, thank you.
Okay, so in the interest of time, I suggest we move on, and Go will hopefully be available for talks or discussion later on. Thank you again.